Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I am Nicola Brook and I'm the solicitor at Broudie Canter Solicitors with day-to-day responsibility for managing our work on the COVID inquiry, and that is on behalf of the COVID Bereaved Families for Justice UK. I'm here with my co-host Lorelei King, who is a member of the group having lost her husband to COVID. Joining us today to discuss the evidence this week are our two guests. Firstly, our most regular panellist, Enda McGarrity, solicitor from PA Duffy, instructed by the Northern Ireland COVID Bereaved. Secondly, and joining us for the first time, is Professor Phil Banfield, who is the chair of the British Medical Association and gave evidence to the inquiry in week 6. Welcome to you both.
Yes, I'm really glad to see you all. Wow, it's been a really full week and an interesting week. We opened with Robin Swan, the former Minister of Health from Northern Ireland. So, of course, I'm going to come to you. And during his testimony, I heard a lot of things, the very things that are quite specific to Northern Ireland compared to the other nations. And I just wonder if you could tell us a bit about your thoughts on his testimony.
Yeah, absolutely. I suppose the starting point is that health has obviously devolved. So Swan's evidence was quite important from a Northern Ireland perspective because it was a big moment for a lot of the families I represent to get answers for some of the healthcare response issues that they had. So the key theme for me was really, and with the Department for Health generally in Northern Ireland, is this idea of not reflecting on things, whether they went wrong or went well, and not learning lessons. And the starting point for Robin Swan was his written statement, where at the end of it, he was asked to provide recommendations or lessons learned, and he was able to muster up two lessons learned. The first one was that staffing levels were not adequate, and the second one was that the chief medical officer had too many jobs. And incidentally, that's a point that we had made in Module 2C earlier this year, and it wasn't initially accepted by the department, but now appears that it is. So when our senior counsel, Brenda Campbell, was questioning Swan, she aptly asked him, is that all? Because up until that point in the 4 or 5 hours which preceded that in his evidence, we had just heard concession after concession on many of the major points. I'll do a quick run through on some of the main issues that were discussed. So there was a general failure to have an adequate plan in place for critical care services being overwhelmed. It took about a month for the department surge plans to be published in April 2020, and that was a delay that Swan was unable to explain in his evidence. It appeared that Swan had outsourced a lot of his work, which is fair enough, but there appeared to be a lack of insight, a lack of direct leadership on many of these key areas from our client's perspective. On the issue of staff shortages, the department failed to put in place a proper system for alleviating pressures on staff within the various hospitals in Northern Ireland. And obviously, Northern Ireland's a very small region. There's 1.9 million people. That's split across 5 geographical healthcare trusts. And one of the points that CTI, Counsel to the Inquiry, Nick Scott, had put to him was there any arrangement for sharing staff across those trusts? Because in some areas there was much more strain than others. And the answer was that there was not. Swan was also questioned on communication failures with families, something that he accepted could have been much better. Although as with a lot of these points, it appears that it wasn't until he was actually asked the question in the inquiry that he had reflected on some of those failures. Brenda Campbell also questioned Swan on failures to investigate concerns around inappropriate or blanket DNA CPRs, and also around end-of-life care. And again, he accepted that the department didn't properly investigate those concerns. Brenda had put the CQC investigation to him in England, and he seemed to think that investigation, which looked at whether there was a blanket use of DNRs in England, also applied to Northern Ireland. It didn't, and he accepted that now would be a good time to retrospectively look back at a lot of those DNA CPRs that were put in place to assess their adequacy. So I suppose one of the major points to summarize was that a lot of his decisions didn't require the benefit of hindsight to get right. And that's something that he relied upon quite a bit in his evidence. He said himself that the job of a minister is to ask the right questions, of the right people at the right time. And the lasting impression that our clients will be left with is that he had failed to do that.
Can I ask you about one thing that I noticed and that I was kind of horrified by? It has to do with the Nightingale Hospital. And we've heard a fair bit about Nightingales in this module, more than we have before. And did I understand correctly that the Nightingale was supposed to be put in some large kind of convention center, and they couldn't get it ready in time, so they put it in a cancer center, a Nightingale Hospital, to deal with COVID patients? Did I understand that correctly?
You certainly did. And actually, it would have been useful to have a visual at Belfast City Hospital. Tower Block is the place they were talking about. And if you could have a visual of what that place looks like, it's a very old building, very poor ventilation, one would have to imagine. So it seems, right from the off, like an inappropriate place to have a Nightingale Hospital. On top of that, the fact that cancer patients are treated in the same building is an obvious red flag. So yeah, that was quite concerning.
That's wild. Professor Banfield, Phil, as you've invited us to call you, were you able to catch any of Robin Swan's testimony?
So yes, I did catch some of Robin's testimony. I mean, it's an interesting situation, and interesting is completely the wrong word as to the dire straits that the health service in Northern Ireland is, and the complete lack of investment and getting the right amount of money into the system. So, you went into the pandemic in a much worse shape than any of the other nations went into it. So, it was coming from behind and almost fighting a losing battle from the start. You don't really have a central health service like the other devolved nations. So you've got these separate trusts, and you've got to deal with each trust one at a time. So it's not conducive to joining things up, and the discontent amongst the nursing and medical staff in the NHS, and the frustrations that they've had with the system in Northern Ireland has gone on for years, before the pandemic, and continued since. So it must be incredibly frustrating for patients in Northern Ireland who already have waiting lists that far exceed any other waiting list in the UK. But actually, what Robin Swan didn't do, which Matt Hancock did today, was he didn't actually try and blame everyone else. So, seeing him think that perhaps there were things that could be done better, and but it doesn't give me any reassurance that things would be improved if there was a future pandemic, because unless you tackle that inherent underlying infrastructure problem that you have in Northern Ireland, you're always going to be exposed to difficulties. Now, the other aspect of the testimony is the issues that were common to all of the devolved nations. It was a really difficult time with services were overwhelmed. And I'm sure that you'll pick me up on that when we talk about Matt Hancock later as well. And it was, a horrible time for staff, and an even more horrible time for patients and relatives. And it all seemed to be full of little bits of direction, and we started to drop out some of the humanity and compassion that we would normally give, because we're trying to survive with the number of patients that we've got at any one particular time. So it's been a really difficult week, I think, to have it listened to, and to have that detachment from the people who ultimately were making the big political decisions, and what it was like both for staff on the front line and the patients and their relatives. It's been a tough listen this week.
It has been. Enda, was there anything you wanted to respond to?
Yeah, actually, I'm interested as a clinician, Phil. One of the points that keeps coming up in module 3, and it came up again with Robin Swan, was this idea of the people at the top, the ministers, not getting the information from the people on the ground. And when I think of Northern Ireland with those 5 separate trusts that aren't always speaking to each other, and maybe not speaking to the Department of Health as effectively as they could be, what is the solution to that from someone in Robin Swan's position?
Well, actually, the solution is one step back, which is probably one of the biggest failures was not to engage public health doctors, who were working locally. Public health doctors are trained in pandemic response. They know what to do. So they are the experts. And what seemed to happen was, because the pandemic was happening so quickly, so rapidly, and because public health had been disinvested in all 4 nations over the previous 10 years, it meant that there was a kind of almost sudden panic of, right, we've got to do something. And then they ended up doing the wrong things. The public health doctors are hugely traumatized still, because they feel they knew what to do and they had the expertise. And if only they were asked earlier, they feel thousands and thousands of lives could have been saved that were lost. And that's the bit to really reflect on, which is, how do you respond? Well, you start listening to the people who have the expertise, who are going to deliver the care. That's where you start. And again, when we talk perhaps about Matt Hancock's evidence later on, that comes out, that clear disconnect between what was going on and the kind of shocking horror of what was going on in intensive cares, but also outside of intensive care units, and being able to translate that into, well, actually, whatever we're being told, this is actually what's going on. I suppose the classic for that is it's all very well saying that these face filtering masks, this FFP3 masks, are only used in so-called aerosol generating procedures, but everyone else is catching COVID. So obviously the masks that you're using somewhere else are inadequate. That didn't need any science, that just needed someone to listen.
Thank you. And Nicola, I know you will have heard his testimony. I wonder what you thought about it.
Oh, I've said this about so many witnesses, but deeply unimpressive. I said to the team on Monday night, I had read over my notes of his evidence, and I was struggling to identify a single thing he'd actually done. And actually something you've just said there, Phil, about the disconnect. People in Scotland may disagree with this, but actually that seemed to me, when Humza Yousaf was giving his evidence, certainly that's something he was quite keen to get across, the importance of listening to people on the front line. He spoke about having post-cabinet meetings where they would invite people in, precisely because they didn't want there to be that disconnect. He did admit, however, that one of their failings was not engaging with, in particular, disability charities and organisations and stakeholders in that field. And that meant that their guidance wasn't appropriate for people living with disabilities. But I think he was able to at least identify that this is important, and not in a way where some people have mentioned it as a paying lip service, but actually that's where you figure out whether your guidance will work in practice. It's all very well having the textbook, but it needs to translate and work in practice if it's actually going to save people's lives. So it was quite an interesting juxtaposition between those two ministers. And again, people living in Scotland may disagree, but certainly the way his evidence came across, he seemed like he was, or when he was in post, he had been trying to do the right thing by people. I think this week, of all the ministers we've heard, I think he's probably come across as being the most humane.
Sticking with Scotland for a bit, Nicola, I think you had some thoughts about Jean Freeman, who is the former Cabinet Secretary for Health and Sport Scotland.
Yes, there were a few things that I wanted to pick up with her. And actually, the first one isn't so much about what she had to say, but what she was stopped from saying. So counsel to the inquiry had asked her a question about how the financial elements of being a devolved nation had an impact on their ability to deliver a response. And she started talking about the furlough scheme and how they had wanted to extend it, but that was refused. And the chair interrupted Ms. Freeman at this point and said that actually the evidence on this isn't clear, and that she wasn't calling evidence from other people who would be able to present the contrary view, and therefore she wasn't going to allow Jean Freeman to give her view on this. That struck me because just a couple of weeks ago we heard from Professor Simon Ball about the Queen Elizabeth Hospital in Birmingham. He was able to give his view of how things worked during the pandemic in his hospital, but there was no one there to present their view, whether it was from a doctor, a nurse, a porter, a cleaner, a patient, someone trying to visit their loved ones. There was no one there to present what might have been a corroborating view, but equally what might have been a counter view. And it just struck me that the chair was going to stop Jean Freeman presenting a view that the UK government would disagree with. And yet we've had evidence where it's been heard in a vacuum. And that to me was quite a sharp contrast.
If we move on to our third devolved nation, Wales, we had Vaughan Gething, former Minister for Health and Social Services in Wales, testimony. I know we have a lot of Welsh bereaved, and I know feelings were running Hi. He said one thing. I'll just say first the thing he said that struck me, and then I'd very much like to come to Phil and Enda. He said shysters made fortunes from their inadequate PPE. And this just makes me so angry because my husband had young onset dementia. He lived in care, and I know they couldn't get PPE. So this issue of PPE enrages me more than I can say. And especially, it struck me when he said that. I don't know why this hadn't occurred to me before. People tend to lay at the door of care homes. Well, the workers didn't live in, they normally came from outside and they were bringing it in. If they had had proper PPE from the beginning, many of those lives could have been saved. And I know they couldn't get proper PPE because I know the manager of my husband's care home was in tears trying to get PPE, which was also seconded to the NHS. So that's a little bit of a sidebar there, but it's just when he said that, just yes, shysters made fortunes. Phil, if I could come to you with your thoughts. You're in Wales. If you could tell me what you thought about Vaughan Gething's testimony.
I've had a lot to do with Vaughan Gething over the years because I was chair of the Welsh Council of the BMA when he was health minister, and then was chair of the consultants committee across the pandemic. And whatever the politics, he has always struck me as being a pragmatist. Of, you know, here is the problem. Can we find a solution? So, for example, we were looking at how to make sure that the terms and conditions of employment for doctors who needed to change what they were doing and where they were working were protected. You know, and he agreed that in 10 minutes. You know, of this was an obvious thing that needed to be done because we need staff to be able to be flexible. None of the other nations managed that at all. The PPE situation, I always got the sense that they were being influenced heavily by the stockpile that was available in the UK. Wales, each of the devolved nations has got, you know, a stockpile of its own, but it was heavily reliant on UK government for replenishment of those supplies. So we ended up having schools printing visors, and in fact, I've still got some of mine from before. We knew that FFP3 masks may be in short supply, and in fact, we were trying to work out ways of being able to reuse them or put them in pillow cases in airing cupboards to be able to use them if we ran out. So we knew all these things were potentially possible. But then the point at which they were saying that PPE is available, it didn't make sense what they were saying about here is the right PPE, here is, you know, that you can separate out people from these aerosol generating procedures, and the difficulty that we had was that the list of procedures was something that was invented before the pandemic, you know, and it wasn't supposed to be applied to coronavirus. We know that the coronaviruses, although most of them were droplet spread, we knew that they could be airborne spread. And it was a lack of ability for Wales to do its own thing in terms of the infection prevention and control guidance. You know, so it was, yes, here is the IPC, it's for nation, therefore Wales must automatically implement it, therefore it must come into each of the hospital environments. Now that left hospitals with PPE. We quite often got perilously close to running out of it, but it left everyone else without anything. So my wife was a GP, and they got given one mask and told only to use it if someone had a cardiac arrest, and that was their mask. So they went to Screwfix and Amazon and were buying masks off there. There was no procurement process or for care homes. And in fact, a number of care homes and a number of hospitals, their staff did isolate themselves from their families, and live in, and try to sacrifice. And certainly that worked for the first wave. But when we got into the kind of May of 2020, May, June, and there was a sense that everyone wanted to get back to normal across that summer. The first wave was going down. We were all saying that means you've got to prepare for your second wave, and it just didn't feel as if this was where it was going. And then we had, Eat Out to help out. And, if you were involved in the health and care system, you were thinking, hey, you've still got an inability to space. You've still got too few beds. You've still got too few staff. You're not testing, so that you're still mixing COVID and non-COVID patients because you don't have the estate to separate them out. Now, Welsh Government did understand that, but was hamstrung really by the state of its health service at that time. So it is I think one of his biggest regrets is us not doing more about hospital-acquired infections. He had some very early data that came from records from Cardiff Crematorium that showed that, and there were an increased number of deaths within the hospital environment and care home environment, and that led into that whole discussion about testing and trying to separate people out in the appropriate manner. But it was just a horrible time.
And was there anything about Vaughan Gething's testimony that stood out for you?
Yeah, I thought he's a strong witness. His background is obviously that he's a lawyer, so it's maybe not particularly surprising that he appeared quite relaxed. But yeah, look, he was well across his brief. It seems that a lot of these issues he has reflected on, and his thoughts on them were quite interesting. So the point that I found interesting, I mentioned it earlier, was that he, as compared with Robin Swan in Northern Ireland, seemed to have more of a direct line as a minister into what was happening in the hospitals. He had given an example of a particularly chaotic hospital. He was given a rundown on what was unfolding there, and he made some interventions. He said he did this by, as he put it, poking and prodding and asking the right questions. So, I'm sure, Phil, you know the substance of that better, but to me it appeared that the situation on the ground may have been no better than in Northern Ireland, but at least there wasn't this log jam of information where the scale of the issues perhaps wasn't appreciated or understood by those with the power to do something about it. And related to that, when asked for his key recommendation or lesson learned, he said that the system needs to be as collaborative and open as possible, so that there is this direct line between frontline workers and decision makers. And that appears to me to be a very sensible suggestion moving forward.
We had our lawyer who represents us, Pete Weatherby, RKC, question him as well. Nicola, do you want to talk about that?
Hi, yeah. So Our questions to Wales were very, very short. We were allowed 4 minutes to question Vaughan Gething and 3 minutes to question Ms. Morgan, and only the questions that have been approved, which makes it difficult to respond to things that have been said in evidence that you might want to pick up or anything like that. I suppose, picking up on the point about PPE, this is where the modular approach of the inquiry makes things feel quite disjointed. So he talked about shysters providing inadequate PPE in order to take advantage of the system. But there's no evidence here about whether that actually contributed to loss of life, for instance, whether that contributed to staff sickness, whether that contributed to long COVID, because it's all separated out. And that to me seems like a real lacuna. And Ms. Morgan was asked about why there was no investigation into the causes of cluster outbreaks. And her response was, but we investigated each individual nosocomial infection, over 18,000, but that it was very difficult to definitively say what the cause was. But that just makes me wonder, well, what's the point of those individual investigations if you can't look at what the underlying cause was? And the whole point of that is to identify systemic issues so that you can fix them. Obviously, there were problems with the estate that meant ventilation was difficult, that meant separation of patients was difficult. But if you're not going to look at the underlying cause, what does that investigation tell you? And that seemed to me to be quite an inadequate response from her. And it just didn't seem to be well thought out either. What was the point of those investigations if it wasn't going to lead to any meaningful change that could save lives further down the line?
And I guess finally we should move on to probably the most well-known witness of the week, who is Matt Hancock, the former Secretary of State for Health and Social Care. I'll just start saying from my experience, I was in the room and we had a little bit of a kerfuffle because we sat in the front row with many of the bereaved, and we hold up pictures of our loved ones. This is our habit. And today, I'm not sure why, the chair, Lady Hallett, asked us, she said, could we please put the pictures down? I find it very distracting. I think I misunderstood. I was very upset in that moment because I thought, you think it's distracting? But it was actually, now I think people behind us were holding it over their heads. So I have to say, I don't feel quite so bad. And that we were then allowed to have pictures of our loved ones. It's very important for us to feel that our loved ones are in the room. I just have to say, first off, and the only thing I will say about this is that I thought the KC, Jacqueline Carey, she was very, very good. Phil, I think, like Matt Hancock, have I got this? I think you've testified more than once at the inquiry as well.
Yeah.
And
yes, I've 3 times I've been giving oral
like
evidence,
Mr. Hancock, and
like Mr. Hancock, but I hope I come across as caring about patients a little more.
tell me your views and thoughts on his testimony today, please.
I found it frustrating. I mean, the number of lines that he came out with, hospitals are dangerous in a pandemic. Yes, but our task is to try and make them as safe as possible. Let's have the precautionary approach. Well, why didn't you then? It's all very well saying you're not in charge, but you are the politician who can make things happen. So I don't think that the members of staff will be very impressed by some of his answers about PPE at all. And he kind of, for me, kept trying to blame the NHS. It's not me, Gov. It's the chief executive of the NHS's job. Well, yes, but it is your job to give the resources to be able to do what you're asking them to do. So it'll be interesting to see what happens. I felt that he was very uncomfortable and just couldn't bring himself to say that the health service was overwhelmed, despite all of the examples that you and I would think that's a system that's been overwhelmed. And I thought showing the clip of Kevin Fong, and I don't know how Kevin managed to hold it together during that piece, but that was reproduced around the country. Now that was what the staff were feeling like. So, you know, what it was like for patients was infinitely worse. But of course, you know, the inquiry is about what should happen next, and it's very certain from our point of view that, you know, and one of the key messages we're trying to get across is it's not about taking a precautionary approach, it's about following the evidence now. And the evidence says that COVID has a significant aerosol transmission. Regardless, we're still failing to protect people in the workplace, and therefore we've instructed our members, and we would hold anyone to in the workplace to say, you know, I need appropriate respiratory protection, you know, regardless of what the central advice may or not be. But so I thought, you know, his answers were unconvincing. You know, we're not overwhelmed. Everyone who needed treatment got treatment. Well, clearly that was not the case. So it was full of contradictions for me.
I agree. And as a civilian, I just have to say, to us, to the breed, all we could see was him dodging bullets. He was combative. He was aggressive. He kept cutting off counsel to the point where Lady Helen, the chair, had to intervene and say, wait for the question. And I just found myself thinking he passed the buck so often, especially to Simon Stevens. In so many areas that I just thought, why do we even have a Secretary for Health and Social Care? Does he have any real responsibilities? Enda, I was sat behind you. I couldn't quite read what you were thinking, but tell me some of your thoughts.
Yeah, well, I'm about to tell you, but I suppose the first thing was that, you know, a really difficult listen for bereaved families, for everyone really. You know, I'm sure healthcare workers would have been appalled at what they heard today. So my view, he was extremely arrogant, defensive, insincere, regularly speaking over CTI, as you said, not answering questions, making these grandiose statements in response to simple questions about what practical steps did you actually take. So yeah, I don't think it was lost on people, and he portrayed himself as kind of a man of the people who was pushing hard against this rigid system to effect change. And I lost count of the amount of times that he said that something was at the top of his mind. You know, ethnic minorities was always at the top of his mind. Was one example, which just wasn't borne out in what happened. So I think leaving the impression, I think, as you said, Lorelei, that he was powerless is quite remarkable. Quite a remarkable thing for the Secretary of State for Health to say. You know, he was the person in a position to effect change, and he didn't do it. So I think today was a pretty poor attempt at self-preservation for him, but I don't think the chair was convinced at all by many of the things that he said.
I agree. And she is a bit of a cold. So she looked like she was definitely tired and losing patience. I just wanted something you just said, and about the grandiosity. And there was this one moment, I can't quite remember who came to him, but he said, someone came to me in tears and said, Secretary of State, we're in a second wave. There can't be a third wave. And it was like Hollywood dialogue written. This is how a lot of things he presented today were. Nicola.
I think the first thing to say about Matt Hancock is how different his presentation was today for his third appearance compared with his first appearance. His first appearance, you'll remember, as soon as there was a break, he steamrolled past everyone and walked right up to the bereaved, walked straight past me, who he must have known I was there on behalf of you because we have a sign right in front of you, walked straight up to all the bereaved and offered himself, if anyone wants to speak to me, I'm here for you, kind of thing. And the visceral reaction from our clients, they were so upset, and a few of us had to step in and intervene and move him on. Contrast
You're right.
that.
I just wanted to say, because I was there, and we just instinctively all turned our backs, and some people burst into tears. It was really upsetting that he was allowed to approach us like that. I'm sorry to interrupt you, Nicola, but yeah, that was a really significant moment.
It was a very shocking moment, and the inquiry have been adamant that all witnesses are warned not to do that, and it shouldn't have happened. And to be fair to them, it hasn't since. But contrast that with his appearance today, where he wouldn't even look over at the bereaved. He would not look at the images of your loved ones that you hold, let alone look at you. But straight out of the gate, he was combative. And I suppose to many that comes across as a sign of strength. To me, that comes across as a sign of weakness. It was like he was constantly trying to second guess where counsel to the inquiry was going. What was their edge with this question? What was the point they were trying to unravel with him? And it just meant that he was tying himself in knots every time he gave an answer to what should have been a relatively straightforward question. He was talking about how, of course, we were in a pandemic, everyone was struggling, but he made it clear that budget constraints wasn't a problem. Okay, so what was the problem? The problem was the formal advice was that asymptomatic transmission wasn't likely, but that they overrode that advice anyway, and it wasn't a big issue. Other things were the bigger issue. He said it was him who recommended that they reduce the ratios, but the actual ratios that were used, that was nothing to do with him. He relied on clinical advice. Talk about the clinical decision tool. He was very shocked because he knew from his conversations with Chris Whitty that he wasn't in favour of it. And yet Chris Whitty has said he was the one who commissioned it with the other CMOs. Matt Hancock claims he was the one who put a stop to it. And I think he had a bit of a jab at the BMA here, saying that they were the ones, or one of them, who were asking for it. And he completely conflated a lot of issues, saying that any decision on escalation of care or DNA CPR should be an individual decision. Of course, we know that, but the nightmare scenario that led to any work on this clinical decision tool in the first place was that you only have one bed left and you've got multiple people who are candidates for it. How are clinicians supposed to decide who gets it? Phil, you can correct me if I'm wrong here, but that seemed to me to be the genesis of why that was being asked for. And he was making out as though it was still going to be a case of an individual decision, and there was a bed for them, and it was just about whether it was right for that person to be placed in that bed, rather than multiple patients competing for the same bed.
Yeah, he was trying to sidestep that as the issue here. I mean, on a daily basis, because we don't have enough intensive care beds in the UK, there are decisions about who gets an operation and who doesn't get an operation based on, is there an intensive care bed? Because the elective work overlaps into the emergency, how many people are being ventilated as an emergency. The difficulty for us was that we were looking at the intensive care units for Italy, and just what was going on there, and our intensive care consultants in this country were talking to the intensive care consultants in Italy, so they knew what was coming. And at the point at which you've got people of the same, you might end up then with 5 people of exactly the same chance of survival. How do you decide? Who isn't to decide? Who's going to have those conversations? Who is going to say whether someone who has got a 90% chance of survival should have the bed instead of someone who has a 50-50 chance of survival? When actually in normal non-pandemic times, you might have someone who's got a 10% chance of survival having that ventilator and that intensive care bed. And that frustration of not having the surge capacity was why we said this is such a difficult thing to tackle on your own. Right, you can tackle it with your colleagues, but actually having some national guidance about the moral and practical considerations. How do you decide? How do you have those conversations with relatives? Do your mother or your father has said, I don't want to be ventilated, or I do want to be ventilated at all costs, even though I know I won't wake up. And some people will say, make a decision one way. Some people will make a decision another way as part of the normal way that we provide care in those and the discussions that we have. But when you get into a pandemic situation and everything is, the kind of descriptions that Kevin Fong was saying about intensive care and, switching one person out of a bed and almost pulling them onto the floor and putting the next patient in a bed, that needs central guidance to do, because you are then in a situation where the burden for one person trying to make a decision is too great. And in fact, actually, the BMA did issue that guidance. Now, we didn't, fortunately, get to that stage of needing to use that in any big way, but patients and general practitioners were making those decisions when they were saying, I don't want to go to hospital. Right? Actually, I don't want to go and lie on a hospital trolley for 48 hours and die in a hospital corridor. Right? Or a GP then saying you would normally get admitted to hospital, but actually, there isn't a bed for you at this point in time. So, your treatment will have to be at home, and you will either make it or you will not make it. These were horrible discussions. And I can't say that we always got it right. No, and I can't say that we always got it right with being able to have relatives there, because quite often the way that the isolation and lockdown was working, it was putting people in different places. So, it was, and I really want that kind of moral and ethical discussion to be had ahead of the next pandemic. Those discussions, during the pandemic, I had those discussions with my mother. And I was so glad that I had those discussions with her. And she died slightly after the pandemic. But actually, it was a good thing to have had. It prepared, and being prepared and having discussions that normally you wouldn't have with loved ones in life is also part of how you prepare for the rest of life anyway. So I thought it was it was a very difficult situation to be in. I suppose the last thing that I want to say about the testimony today from Matt Hancock was I really resented how he seemed to be blaming the NHS for the nosocomial infections when it was an NHS that was set up to to not be able to limit it in the way that it could have done with better guidance and support centrally from government. And that is what the function of government should have been.
Yes, I think I can only imagine the frustration that anyone who works in the NHS feels on hearing this testimony. We mentioned about the DNRs and deciding who gets care, and he said in his testimony today, my view was that these decisions should not be taken by ministers. But I seem to remember that last year when Simon Stevens, the former NHS England chief, gave his testimony, in his witness statement, he said Mr. Hancock thought that he, not doctors of the public, should decide who to prioritize if hospitals became overwhelmed. That was one of many contradictions that I found today. And as we've been discussing here, Professor Fong, I tell you, he was such an amazing witness, and we saw that clip today. That was really hard for people to see, and there were a lot of tears in the hearing room, not from the witness, but from the people watching. How did you find those moments?
Yeah, I was there at the time when Professor Fong gave his evidence, and he's probably the star witness, maybe apart from yourself, Phil, in module 3. You can have that joint title. But no, in terms of the substance of what he was saying, it's so important to have that on the ground experience in hospitals. And I suppose it's the difference between him and Matt Hancock. Hancock mentioned a couple of times spending a night working in a hospital. Professor Fong was there. He's seen what was actually happening. He's seen the NHS being overwhelmed. Hancock pretended that he's seen the extent of it, and his conclusion was very different, that the NHS was not overwhelmed. So it's really that juxtaposition between those two men, and I think the inquiry will very much prefer Professor Fong's evidence to that of Hancock's.
Nicola, you had some thoughts about Mr. Hancock's temper?
Yes. So one thing I've noticed this week is there has been an attempt by, I think, all the ministers, but I'm happy to be corrected if it hasn't been all of them, but to shift the definition of what overwhelm means, because I think they've all made public statements that the NHS was never overwhelmed. And they're all now at pains to say that's true, but maybe that depends on what your definition of overwhelm is. And at one point, counsel to the inquiry was saying, we've shown you evidence of, and he cut her off and said, yes, you sent me loads of pages of this, that, and the other happening, as though I wasn't there. And just picking up on what you said, Enda, about, he maybe did a day here or half an hour there, but he really was trying to make out as though he was on the front line, which must just be so insulting to people who actually were. And one thing I would have liked to have asked him was, what mask was he wearing when he was pulling those occasional shifts? I wonder whether it was a hood or an FFP3. I bet it wasn't an FRSM. But actually, I think we maybe got close to something of the truth with him when he talked about PPE, because he said that no, supply, that didn't dictate what the advice was. But then he did say that the advice has to take account of the reality of the supply that was available. And so he did concede that it was a factor in the advice. And it feels like for best part of 9 weeks, we've been gaslit by all these people from the IPC cell saying supply was never taken into account. We just didn't have any evidence to recommend an FFP3, other than if you were doing an AGP, an aerosol generating procedure. And that brings me right back to the evidence of Barry Jones, who said on this very podcast, a cough is a cough is a cough. Doesn't matter whether the cough is caused by a spontaneous cough or an aerosol generating procedure. people with COVID were coughing. And if you are working in that environment, you need an FFP3.
Preach. Yeah, Phil.
It seemed to me that Matt Hancock was saying that the advice was being driven by availability of PPE, despite the IPC's cells saying otherwise, and that's what it felt like on the ground floor, on the top floor rather. We had medical students went out of their way to volunteer very early on in the pandemic, and were told that they didn't need to have FFP3 masks, and yet they were taking bloods on patients who were clearly coughing COVID all over them, and just one by one they all got COVID, right? An entire group of medical students that were up on placement with us, and just think that didn't need any science to then tell you that you've got the wrong protection. And we were fortunate. We changed it quickly within our maternity unit. So we used FFP3 masks throughout, just ignored the IPC advice, because actually the employer has a duty of legal duty of care to protect the employee, and that doesn't supersede the IPC. The IPC guidance doesn't supersede the legal duty, which is why we're frustrated, obviously, with the health and safety executives' attitude.
Thank you. I think I'd like to now ask you all for your standout moment, standout witness, highlight or low light. I'll start with mine, which was during Matt Hancock's testimony. It's a small thing, but it was when we were talking about inequality and BAME doctors, and he said the first 4 doctors who died were BAME. And then he went into this extraordinary speech that was like something a 15-year-old would write in an essay paper about how it shouldn't be about the color of your skin or the color of your eyes. It should be about your hopes and dreams. Honestly, and my standout moment was when the FEMHO lawyer, Leslie Thomas, kind of slapped him down on this and said it was actually 10 doctors and took him to task. And I couldn't help contrasting what Matt Hancock said to something that you said, Phil, in your testimony. I think last year you said the best phrase you've heard about this situation is that we're all in the same storm, but not in the same boat. And I think that was a much better way to put it. So that was a little standout moment for me today. Can I come to each of you? Enda?
Yes, mine came from an unusual source with Matt Hancock. Probably the only thing I agreed with him on was his comments when asked about funding, essentially. He wasn't asked about funding. He kept trying to move the conversation onto funding, and CTI was trying to steer him away from that. Something that I think is probably deficient with the inquiry is that they're not, you can't look at healthcare reform without looking at funding at the same time. And if we look at Northern Ireland and the dire state that healthcare is in there, the hospital state doesn't get updated without being properly resourced. That would be a really good starting point in a future pandemic, to have safe hospitals where they're single rooms, for example, as another witness had mentioned. So I actually think that point is right, and I think it's something the inquiry should be looking at.
Yeah, he was in the government in power, wasn't he, when they were deciding about funding the NHS? Oh, well. Phil, what was your standout moment?
Well, I mean, I've got 2. One was him trying to convince the world that he had made it a better place by bringing the ultimate responsibility for the NHS back into government by changing the Health and Social Care Act 2023, and omitting to say that they had, of course, abrogated responsibility from the Health and Social Care Act 2012. So I thought, trying to put that as a victory when in fact actually they'd caused it disaster in the first place, I thought was a bit of a try on, but also trying to convince GPs that he loves GPs and wasn't behind the demonisation of face-to-face contacts. I mean, GPs saw people face-to-face. They had to do virtual consultations, and in fact, it's one of the successes that general practice was able to switch overnight. Because if you think about the way the NHS adopts any innovation, it normally takes about 10 years. And literally, general practice did this overnight in collaboration with some software and app suppliers whose motivation was not money, but to get the job done. And I was well impressed being part of that myself. But, to say, he wanted virtual consultations and then wouldn't defend them against the face-to-face. That's the letdown of leadership that the GPs, I don't think, will ever forgive him for.
And Nicola.
My highlights this week, I'm going to do something I've never done before. I'm going to give my highlight to the chair. And it came from the chair's comments to Matt Hancock. Firstly, his definition of overwhelm. He said that during the pandemic, everyone who needed care got it. And the chair retorted, well, not if you needed cancer screening and not if you needed a hip replacement. So that was moment number one. And my second one was right at the very end of today, where Matt Hancock was saying he would be there as long as they needed him to answer questions. And the chair said, no, it's been rather a long day for you. And I think what she meant, or certainly what we all thought, was it's been rather a long day of you. And that was my moment.
Yeah, you're right. That was funny. You have to laugh.
So it's important to say that we've recorded this podcast at the end of day one of Matt Hancock's evidence. He will be coming back to conclude his evidence tomorrow. So at the moment, only a few of the CPs have had the opportunity to put questions to him. We, on behalf of COVID Brief, Families for Justice UK and Northern Ireland, will be putting our questions to him tomorrow. We will be going last, and we've been given 20 to 25 minutes to do so. So there is still much more to cover with Matt Hancock, and we will make sure that we include that in the podcast we record next week.
I'm just so grateful, as always, to all of you for making the time after. I know Enda and Nicola, you've had really long days, and Phil, thank you so much for joining us. And I know the podcast means a lot to a lot of people, so thank you.
That's a pleasure. Thank you for the invitation, and I really do hope that you get the justice that you're seeking.
Thank you, everyone.
Thank you.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.